Good morning, everyone, and welcome to our new remote MDT, which is a new change that we have started in response to the COVID pandemic. So this morning, can we start with the newly diagnosed patients? And I would ask you all to identify which study they can go into, which includes the COVIDSurg and the CovidSurg Cancer cohort studies.
Sure. So our first patient is Amara. She's a 61-year-old lady, presented to clinic with anemia. She's pretty well. She has a performance score of 0 and no significant past medical history. She had a colonoscopy, which showed a cecal tumour, and that was biopsied. And then she's been for CT staging. So we should have results for both.
Yes, specimen 1 labelled cecal biopsies show poorly differentiated adenocarcinoma with high-grade dysplasia. Specimens 2 to 4, ascending colon and rectal polyps, were low-grade tubular adenomas.
Regarding imaging, the CT demonstrates a lesion in the cecum, highly suspicious for a T3 cancer. There are no obvious malignant local regional nodes and no evidence of lung or liver mets. So I would say that radiologically, this is a T3N0M0 cecal cancer.
Okay, we will offer her a right hemicolectomy. But because of the COVID concerns, as a department, we've decided to do these as open operations for the time being. It doesn't sound like she needs a critical care bed, so I'll book her a post-operative ward bed. It might take a little bit of time to find a COVID-free operating theatre and COVID-free ward. So if she is delayed, which of the studies can she go into, Mary?
Well, she can be included in CovidSurg Cancer even if her operation is delayed. In that case, we'll follow her up for 3 months from this decision now, or if surgery is done sooner, for 30 post-operative days.
Mr. Baker's a 58-year-old man who presented to me with altered bowel habit and incomplete emptying. He's had his colonoscopy that showed a tumour in the upper rectum, but the rest of his colon was normal. I think by now he's had his CT and MRI. So do we have biopsy results, please?
Yes, I have rectal biopsy showing moderately differentiated adenocarcinoma.
Well, the MRI displays a 35 millimeters anteriorly located rectal tumor at about 9 centimeters from the anal verge, with 3 millimeters invasion beyond the muscularis. There is no EMVI or the CRM is not threatened, and there are no obviously pathological lymph nodes on radiological criteria. About the CT scan, it doesn't demonstrate any liver or lung metastases. So I would consider that radiologically it's a T3B N0M0 rectal cancer.
Okay, thank you very much. Pre-COVID, we would normally offer him a laparoscopic anterior resection, but due to our COVID position at the moment, we'll do this as an open operation. I would normally have a discussion with him about the risks and benefits of a defunctioning ileostomy, but I think in this case, I'm going to recommend that he has that defunctioning ileostomy, because if he has a leak after the operation, taking him back to theatre again, or finding a critical care bed may be more difficult than normal.
Okay, well, he's coming to clinic tomorrow. I'll see whether we can get a theatre slot, but even if his operation is delayed due to COVID, he can go into the CovidSurg Cancer study, and changes in practice like conversion to open that have occurred due to COVID, we can record as well.
Next patient is Mr. Cook, who's a 55-year-old fit man who's got a tumour in his ascending colon. And he's been pre-op staged already with a T2N0M0, and he had a right hemicolectomy 2 weeks ago. And that was just after we stopped doing laparoscopic work. Do we have histology results, please?
Yes, we received a specimen labelled right colon at 6 centimeters from the cecal pole. and 3 centimeters from the distal resection margin, there is an ulcerated round tumor measuring 3.2 centimeters in diameter. The rest of the mucosa is grossly unremarkable. The tumor invades through the muscularis propria, but not into the pericolonic adipose tissue. The serosal surface is not involved. None of the 32 lymph nodes were involved. Margins are clear. T3, N0, M0.
Okay, well, he's got no high-risk features, so fortunately, he doesn't need any adjuvant chemotherapy in this case.
Great, he's a nice guy. His operation was delayed in reshuffling everything, and then unfortunately he had fever day 5 post-op just before he was going to go home. So he actually had a SARS-CoV-2 positive swab, but despite the fever, he didn't have any pulmonary complications and actually has been discharged and he's well. So because of that co-infection, he's been entered into both COVIDSurg cohort and the CovidSurg Cancer studies.
The next patient is Deirdre Diamond, who's a 56-year-old woman, and she had an anterior resection 12 days ago, and that was after her negative pre-op COVID screening, and that was for a descending colon cancer. Her pre-op staging was T3N0M0. Do we have her pathology results now, please?
Sure. We received a 15 centimeter section of colon with 36 lymph nodes. There was a 4.6 centimeter poorly differentiated adenocarcinoma. Tumor invades through the visceral peritoneum. Distal and proximal margins were clear. There is clear perineural and vascular invasion. The lymph nodes are negative though, so T4, N0, M0, but V1.
Okay, well, from an oncology perspective, in normal times, I'd have liked to have offered her chemotherapy, but I'm a bit worried that the 5% 5-year survival benefit in pre-COVID times might be countered by the risks of COVID during the pandemic. So I think probably expectant management in this case might be more suitable for this lady.
Thank you, and I think I agree. I'm glad we managed to do her operation. So this lady can go into the CovidSurg Cancer study, I think, and we can report an alteration in post-operative care due to COVID. Mary, is that right?
Yeah, exactly. In terms of follow-up post-op, that will be 30 days.
The next patient is Esteban El Dorado, who's an 87-year-old retired carpenter with hypertension, diabetes, angina. He's got a hepatic flexure tumor that was seen at colonoscopy for altered bowel habit. Now, biopsies originally showed a poorly differentiated adenocarcinoma, and his staging CT showed a tumor at the hepatic flexure that was called as a T3N1M0. He was supposed to have an operation, but this was cancelled twice due to capacity issues as a result of COVID. He wasn't suitable for neoadjuvant therapy at that time as the risks outweighed the small benefits. But he had a repeat CT scan 2 days ago. So, Joanna, do we have the results, please?
Yes, we do, Neil. So I'm afraid to say that compared with old imaging, the disease has progressed. He now has metastasis in both right and left lobes of the liver in segments 3, 5, 7, and 8.
That's unexpected, but we can't offer him a curative operation now, even with the liver surgeons, because the risk will be very high with such extensive surgery at the time of COVID. So do we remove him from the study now, Mary?
No, we can keep him on because we decided originally for curative operation, he'll go into the COVID cancer study regardless of whether the operation is done or cancelled. And we can follow him for 3 months. And the purpose of the study will be trying to find out what happens to these kind of cases where COVID has altered their outcomes.
Okay, thanks very much. I'll see him in clinic.
So the next patient is Francois. He's a 58-year-old we discussed in January with a T2N0M0 mid-rectal cancer. And he was awaiting anterior resection, and then COVID started and things changed.
Okay, and we don't have capacity to do him at the moment, despite looking for space, and I'm not sure when we can do it. So, James, do you have any oncological options?
Yeah, there is another option. We could offer him some radiotherapy while there's no theatre capacity.
Okay, thank you very much. That's not what we would do normally, but that's a COVID-related decision. And of course, we'll have to assess his response to radiotherapy afterwards, and he might do quite well from the radiotherapy, in effect. So, Mary, again, do we keep this gentleman in the study?
Yeah, that's right. Let's keep him on CovidSurg Cancer. We'll follow him for 3 months because he would have been going for curative operation in other times. So his care is altered by COVID.
Thank you. The next patient is Gabrielle, who's a 49-year-old man who presented to the emergency department with rectal bleeding and altered bowel habits. He's been in for a flexible sigmoidoscopy that revealed a rectosigmoid tumor that was impassable with the colonoscope, but it was negotiated with a gastroscope. The rest of his colon was clear. So biopsies, CT and MRI should have been done now.
Yes, this was a moderately differentiated adenocarcinoma with lymphovascular and perineural invasion.
His original staging was a T4N2B M0 cancer, and he had a positive left pelvic sidewall lymph node. He's been for neoadjuvant chemotherapy, which is complete, and he's had repeat imaging since then. So do we have those results, please?
Yes, we do. Well, both CT and MRI after chemotherapy showed disease progression, Anil.
Okay, that's disappointing, but I'm seeing him in clinic on Tuesday, and I'll need to discuss this with him and his partner. And any oncological options, James?
Yes, so, we can offer him some short course radiotherapy now.
Thank you. I'll make that offer and referral. Mary, does this patient go into the CovidSurg Cancer study as the treatment's been altered?
Well, no, because we never got to the point where we could offer him, or we were planning to offer him curative surgery, so he doesn't go on.
And the final patient today is Harpreet Haji, and lots of our patients seem to be presenting a little bit later these days. Mary, do you have the details for this patient?
Yeah, this is a 64-year-old who came to emergency department with a cecal perforation due to an obstructing sigmoid tumor. So we did a subtotal colectomy. She had an endoleostomy, and that was 10 days ago. Do we have histology, please?
No, I'm sorry, not ready yet.
Okay, well,
okay,
that's understandable, but we'll review it next week. So does this patient go into either of the studies?
No, she can't go into either actually, unless she's unlucky enough to get COVID in her 30 post-operative days, and then she could go in the cohort study. But to be entered in the cancer study, she needs to have a known cancer planned for surgery. So most of our emergency presentations are not eligible.
Okay,